But overall, when we come to NCDs such as diabetes, we've got real issues, which you can see there, rates increasing, which puts further pressure on healthcare systems and obviously further pressure on available resources for children. Part of what I've been speaking about, we published in a recent paper, so that's available online as an editorial, building on some of the comments that I've already made. So we come particularly to the diabetes as one of the key non-communicable diseases that we see in Bangladesh. I think a key issue, obviously, going forward is a shortage of trained personnel and facilities. So maybe there's a role, as we see now in Africa and a number of other countries, for community pharmacists to get more involved. Sorry, somebody just taken over control of my screen. Can we go back up a slide, please? It's a particular issue, obviously, with trained resources, so with trained personnel and things like that. And I think that's an issue we've got to look at. And as I talked about, maybe a greater role for community pharmacists going forward, as we see in a number of countries to help with issues such as sort of diagnosis and things like that. So maybe something we can talk about for Bangladesh. Obviously, co-payments are an issue, and particularly, obviously, the costs of patients once they get diabetes, particularly complications. So I think a previous speaker or previous chairperson talked about increasing prevention and putting more emphasis onto that. And I think that's particularly important with Bangladesh, particularly for the children going forward, to stop them from getting some of these diseases, and also that their parents from dying early. Also, I think one of the big issues across most of low-income countries is actually recording what's going on. And we're doing some recent work in Bangladesh where that's a particular issue. I say that, I'll just put on this next slide for Sweden, because where I work in Sweden, they're very comprehensive patient records. You as a person, once you're born, are given an automatic number, and that's your health service number, your driving license number, your social security number, etc. So we can track very well patients through the system. So that enables us to do some very comprehensive work, looking how we're currently managing patients, and particularly here, obviously looking at new expensive medicines coming through and whether they are producing their value in practice. So this is a system we recently published on. So as we go forward in Bangladesh and other things, one area that hasn't probably been discussed that much is how we improve our record keeping and making an increase in the use of electronic data systems that we go forward to help improve our management of NCDs across all the population. So these are some of the factors in our recent pilot study that we're just getting the final reports from, review reports. So we hope to have this accepted in a not too distant future. So this was mainly in adults, but I think we can look at this in all patients across Bangladesh. So firstly, obviously, we've a concern with the paper record systems, particularly if they're held by the patients and not held by the hospital, and there's no electronic documentation. Under those circumstances, it's actually quite difficult then to follow patients, as we've seen. Regarding specifically looking at diabetes, this is more in an adult population, there was generally poor control of blood glucose levels, leading to increased prescribing of insulin with all the issues around costs that's involved. Although there was better control of blood pressure and lipids, etc. So that's again as important as patient population, because that reduces your level of complications, etc. What was good for me is that there was a generally greater availability and prescribing of medicines to help not only control blood glucose levels, but also look at issues such as blood pressure, lipids, etc., compared to what we have seen across a number of the other low and middle income countries. So that's very good going forward. Although, as I said earlier, a key concern was a lack of really information in the notes that the patients had, that they took around with them or in the hospital, etc. And that was obviously made worse during the COVID pandemic with a lack of access to clinics, etc. So to me, that needs addressing going forward, that this is a key area to work on. What was encouraging for me, though, was, and we looked at the use or the availability of long-acting insulin analogues across Asia and Africa and Central and Eastern Europe. And what we did see was good availability in Bangladesh. So that gives me encouragement going forward that there are available resources in the healthcare service for patients to be prescribed appropriate medicines for their conditions. So That's one hurdle that we don't see in Bangladesh that I have seen across a number of the other lower middle income countries. So that's something that we can build on going forward with the other areas that I talked about to help improve care of these patients. So this is just a paper that we recently published on patients with diabetes in Bangladesh. And we didn't break them down by age. We just were looking at some of the availability of the different insulin preparations. This is what we compared with Bangladesh across other Asian countries, including Malaysia, etc. And then more globally, this is looking at Bangladesh versus Asian and South American countries and African countries. And what we see across African countries is a very low use of the long-acting insulin preparations just because they don't have the resources. So that's what I meant, and similarly in South America. That's what I meant about Bangladesh versus some of the other Asian countries and Afro-African countries and South American countries that I work with. So to me, that gives me hope going forward. But as I say, a key issue, particularly in Bangladesh, is how we improve our diagnosis and how we better monitor the patients going forward. So that was just my last point I'd like to make in the time I have available. Is firstly for me is looking around the issues of diagnosis and management. So how do we improve our diagnosis? How, particularly in children, identifying them early if they have type 1 diabetes, or as they move into adults, about how to better management. So to say maybe community pharmacists can help with that sort of activity as we go forward. Obviously, we've got to look at issues of copay if they're an issue, and that's just not of medicines, but it also of glucose strips and things like that. Where I work in Africa, they're just unaffordable to patients. So how do they control their HbA1c if they can't sort of monitor? So if they're given insulin, they're not given the insulin strips to help the strips to help to monitor their HbA1c, etc. So it's very important not only have the medicines available, we have the means to be able to use them appropriately. And obviously, expansion of educational programs, we talked a lot about. We tend to try and put a lot of resources into these patients once they get complications, but not to prevent them. So I think that's an issue going forward. And also how we look at disseminating guidelines. I know the WHO have put a lot of effort into this. We got new guidelines for hypertension and things like that, and also some work around what are cost-effective interventions. One of the things to look at, and I know my colleague Aman Kurdi would be talking a little about this tomorrow, is what about putting in quality targets? So the UK has put in quality targets around percentage of patients with diabetes that reach HbA1c targets, percentage of patients with diabetes or on having their hypertension correctly management, or they're on a statin, or they're on low-dose aspirin, things like that. So I think that's something that we can put into place in Bangladesh as we move forward and we improve our record keeping, to put in place quality indicators, particularly in the public healthcare system, improve our management of these patients. That has worked well. And lastly, one of the other key areas is looking at adherence to guidelines, because we know that works with improving care, and as long as they're robust and pragmatic, then they can really help improve the care of these patients, including our children as well as our adults. So that's all I've got to say. So thanks very much for inviting me, and I hope I've helped stimulate some questions later on.
Question answer session at the end of that, another two speakers. So now I am inviting our next speaker, Dr. Bedoura Zabin. She will be also online. Dr. Bedoura. She is a consultant pediatric and endocrinologist and Department of Pediatrics and coordinator of Pediatric Diabetic Center at Bardem.
Assalamu alaikum, and very good afternoon to you all. First of all, I'm thankful to the organizers for inviting me to speak on this very important and burning issue, I should say, that is situation of pediatric NCDs in Bangladesh. I have shared my screen. Is it visible to
Yes,
all?
we can see it.
Okay, thank you. So respected chairperson and chief guest and all the distinguished guests, I will speak on this topic for next 15 minutes, I think. Yeah. So this is the outline. And we know that NCDs is a global problem now, and especially for adolescents While they are often associated with adulthood NCDs, usually we think that we have an idea, well, it's for the adults, but nowadays we have seen in different studies, researchers, that the NCD is starting from children and adolescents. So this is the time where we should provide our key prevention program. So we know that this is a chronic disease and there's a long duration. And of course, there is combination of genetic, physiologic, and behavioral factors are there for the development of NCD. There are lots of research have shown that it starts from very early years. And we know most of the risk factors are preventable and it's modifiable other than non-modifiable risk factors. If we look into this figure, we can see the most of the NCDs like diabetes, cardiovascular disease, cancer, and chronic respiratory disorders, and also mental health disorders, we know is rising even in children and adolescents. Overall, if we look into this, that obesity and overweight is now considered both not only the risk factors, but also the NCDs. And more than 2.1 billion children are affected by NCDs in the world. And as we have heard that many of them are from, mostly 2/3 of them from the lower and lower middle income countries. Just a picture of all the NCDs, the latest data that, and we can interestingly see that mental health disorders, yes, is rising, and almost to 31 million adolescents are having MHD in the world. Now the Bangladesh scenario. Interestingly, if we look back to the few decades back, we know we had to fight with the malnutrition in children in our country. But yes, now we are facing the dual burden, that is both malnutrition and also the obesity. And the main drivers of this epidemic are of course, the rapid urbanization, industrialization, changing the food system, and the reduced physical activity. And since 1975, this has been tripled in the world. If we look into the mental health problems, WHO estimates that around 20% of adolescents have mental health problems in our country. This is a recent study. If we look into the study, that is almost more than 4,600 participants were there, and around 28% were overweight. And majority of them, like 55.7%, had moderately stress. And among highly stressed adolescents, that's the finding, that's 28.5% were almost overweight and obese, which we are talking about today. And on the chronic respiratory disorders, we know the most common in children is asthma. And children and adults who are, we know already, but also again, we have to emphasize on that children and adults who are overweight and obese, they are at greater risk of this chronic respiratory disorder or asthma. This is another finding, that the prevalence of asthma was like 7.3%. Earlier in 1999 and 2010 is almost like 5.6%. And in Bangladesh, it is estimated that around 9,000 to 12,000 children develop cancer every year. And this is another study done in 3,143 children and adolescents. And the most common was the leukemia and lymphoma in the 2011, and now it is like 25%. And we can see that the malignant bone tumors and germ cell and gonadal tumors are there also. Now, the very important part is the cardiovascular disease in children. We know that hypertension is one of the common disease in CVD, and in our children also sometimes it is actually unnoticed, because if you don't go for measuring the blood pressure in child, you cannot even don't know that he or she is developing hypertension. So this is very important to detect early to prevent the complications in early years. And also we know that chronic heart disease is another disease, cardiovascular disease, which occurs from rheumatic fever in children. So this I should say this is very encouraging that this study showed like 56,800 children were participated in this study, and the prevalence of rheumatic fever was only 0.6 per thousand, and rheumatic heart disease was only 0.3 per thousand. It means that it's going to disappear gradually from Bangladesh. And if we look into this survey of hypertension in school-going children, we can see that prevalence was like 1.8%. And it was done in more than 1,000 children and adolescents in Dhaka City School. And the author concluded with that it exists, it is related with obesity, increased BMI, and family history, of course, and dietary habit. Now the main topic, that is the obesity. In 1980, you can see 3% were overweight or obese in Bangladesh, and it's rising and rising. The recent study done in 2013 in 4,100 children revealed like 10% were overweight and 4% were obese. And this is the study we did in a district school. It's outside Dhaka, and you can see it's really alarming. More than 600 children and adolescents were screened, and we found that 23% were obese and overweight, and 4% were obese. And another thing is very important, that this finding that waist and height ratio among this group, you can see which indicates the central obesity, and you can see even the children who were of normal weight, they had the central obesity. And there are lots of studies done with the obesity in Bangladesh so far. And one recent study, like 9.5% were overweight in 6 to 15 years old children. It was done in 10,315 school-going children. And of course, the urban schools were more than the rural schools. And another study, yes, there was around 20% were overweight. Sorry, yeah. And we also did a study, and we found that the BMI was very high. We compared with the two groups, that is privileged and underprivileged students, and we found it very high in the privileged schools. So now the diabetes, if we look into the diabetes, we know that two types of diabetes are there, type 1 and type 2, and type 2 is more common in children, of course. But we know at the same time that type 1 is not preventable till now, but we can manage it very nicely. And regarding type 2, yes, we can prevent even in children. So it is estimated by the International Diabetes Federation that around more than 17,000 children and adolescents less than age 20 years are having type 1 diabetes in Bangladesh, and the incidence is estimated 4.2. And in Burdem, we are having the largest pediatric diabetes clinic, where we have mostly around 7,000 children and adolescents who are registered here. And every year, almost 500 to 600 new patients are registered. If we look in our recent study done in Burdem, we just see that from 2011 to 2018, we saw screen the data of retrospectively. We look into the data from the Dhaka city. You can see that type 1, that's not rising like that, the incidence. But in case of type 2, you can see from 2011 to 2018 is a real great rise of children in our center. Also, we did other studies in our center, and from 2010 to 2015, we can see that from 2% to 14% were type 2 diagnosis in our center. And another study, we found around 18%, and recently we got like 20% type 2 newly diagnosed. And another point is very important. We know that gestational diabetes mellitus, and we found that in these children, there was history of 20% that mother was having GDM in this pregnancy. And from the Diabetic Association Bangladesh with the Ministry of Health, we did this project for 2 years, and it's going on also. That is the Kaji project, that counseling of newly married couples. And 30,000 newly married couples were given this care, and 4 million community people got information for this pre-conception care, because this is very important. As we have seen, this GDM is another factor of developing type 2 diabetes in children. And 1,800 newly married couple took pre-conception care package, and about 80% found normal OGTT at 24 to 28 weeks of pregnancy. That's really encouraging. These are our collaborators who work with this project and in working. And this another, I should mention here, this is very important, that is community mobilization. It was done by Professor Kishore Azad and her team. In Faridpur, it is a village, and women group were given this, were working with the community people. And we have seen that the mobile health and PLA activities, it reduced the hyperglycemia and diabetes as well, more than 60% in the villages. And we are working, it's very important. Now we should work for awareness, and we are already working for awareness and screening program in schools and the community from our Diabetic Association Bangladesh on the World Diabetes Day and other times also. And this is this is very important poster, I should say, that the awareness of the if the child is having the signs of warning signs of type 1 diabetes. We usually distribute to the schools when we go for a screening program, camps for children. So this is very important, that type 2 diabetes is really, we have seen that it's becoming more common in Bangladesh as well. And of course, it is preventable. So we know that government of Bangladesh has introduced lots of projects on this and lots of programs as well. And one of the most effective, we should say, initiatives was the establishment of the NCD corners at the Upojela health complexes. And we are glad to work with these Upojela health complexes. We have already, the Diabetic Association Bangladesh already has started the first phase program with this, that we are also starting to work in the Upojela health complex with, in the first phase, we'll develop 100 centers. Gradually, it will be like 500. So I would conclude with saying that overweight and obesity, as well as related non-communicable diseases, are largely preventable. So preventive policy should be there, and it should start from the preconception plan, as because we have seen that GDM, high prevalence of GDM here, and also the type 2 diabetes of development of type 2 diabetes in children from this GDM mother. And also we need some intervention studies, like pilot studies or whatever, and then in large scale to see the effect of this support. And multi-sectoral comprehensive effort should be started with involvement of government and other stakeholders to combat this disease and to reduce the adverse outcomes in adulthood. So now the time to act on NCDs and time to act on childhood obesity. We should all work together with the government to combat these problems and to reduce the complications and to ensure the better quality of lives in children in Bangladesh. Thank you all for your patience hearing.
Thank you, Dr. Bedoura. That was very good presentation to understand the situation of pediatric NCD in Bangladesh. This was also the keynote paper. Now I will invite our next speaker, Dr. Thancho from Unicef.
Hello and good afternoon to everybody. Can everybody hear my voice from the Zoom, my colleague?
Yes, it's clear.
Okay.
Thank you.
And can you see my screen in the presentation mode?
Yes, it's visible. Thank you.
Thank you very much. Yes. Good afternoon to everybody. So I would like to thank Dr. Margub from Unicef for introducing me into the stage. And I would like to also thank to our chairman and our chief guests for honoring us with these sessions. And I would like to show my appreciation to the previous speaker, Dr. Bedoura, for her detailed presentation about the burden of the NCD, especially on the pediatric that is happening around the country, around the world. So I would like to start my presentations. So as you have gone through the days, today we have learned so much information about the burden of the pediatric, including the scientific and also the other narrative that are happening around the world. So today I would like to present about the UNICEF intervention activity, how we are going to tackle the burden of the pediatric NCD in the country. So I will go very quickly on this background, as the previous presenter has been covered lots of points. As you already know, the NCDs are now one of the target within the Sustainable Development Goals. They are under the goal area 3, the good health and well-being. They are the target 3.4. The target is to reduce the mortality from non-communicable disease and promote mental health. So if you look at the current situation that are happening around the world and around the other countries, not so much action, not so much political action, not so much advocating are happening on the NCD. And another burning issue is the not sufficient in terms of both domestic and international finance for tackling this NCD. And the last ones that are happening across in many low and middle income countries, the health system is not strong enough. That is including the limited progress on achieving the universal health coverage. So what has been happening around the world? So in terms of the UNs, UN has formed the United Nations Interagency Task Force on NCD. So this one is the combination of more than 40 UN agencies in order to tackle the burden of the NCD, that is including the adult and pediatric around the world. So in this task force, they have the 4 main priorities. Priority number 1 is to support the country to deliver the multi-sectoral actions on the NCD-related SDG targets. And number 2 is to mobilize the resources. And 3 is to implement the harmonized action and forging the partnerships. And 4 is to becoming exemplar for the UN reform. And this slide shows how UNICEF is going to intervene in terms of the prevention and treatment of the NCD at all levels of the life cycles. And when we are talking about the NCD, we need to keep in mind that it is starting even before the life has begun, which means this NCD could begin within the pregnancy. So we also need to take care of the pregnant mother. And at the same time, after the baby is born, we need to look after the infants, following his progress together to the adulthood, throughout the adult and throughout the family. So that's how we are going to implement our intervention areas. So in the recent years, our UNICEF has developed the approach to the health system strengthening and universal health coverage that are critical for tackling the NCD, such as enhancing equal access to prevention, screening and care, mitigation, and socio-economic impact of ill health. If you look at this slide, you are seeing the UNICEF, the strategy for the health for 2016 to 2030. This is a strategic framework for NCD prevention, how UNICEF is going to do the strategic area for prevention of the NCD. So mainly we are going to tackle the 4 areas. Area number 1 will be to advocate the child right to the health. That is, we are going to support the capturing of the data. We're going to engage with the development partners, INGOs, local NGOs. And the second area is to influence the government policy. By supporting the evidence-based data, we are going to support the government in terms of making the evidence-based policy making and the financing. And the third one is to strengthen the service delivery. So in order to tackle the burden of the pediatric NCD, we need to build the capacity of the service provider. And the last one is to empower the community, because NCD cannot be tackled alone by the health sector, because NCD is a multi-sectoral approach. Therefore, we need to collaborate with the other departments, which at the same time, we need to advocate not only the service provider, but also the community at the ground level. So by looking at this slide, you can see how UNICEF is going to tackle the pediatric NCD in the country. So by leveraging the existing activity across the UN programs that that are occurring in the headquarters, regional, and the country office, UNICEF is well positioned to incorporate the multi-sectoral approach to the NCD. So to give you a brief area where UNICEF is going to implement in the Bangladesh is the number one is the rheumatic heart disease. Number two, it would be the type 1 diabetes mellitus, asthma, and the sickle cell disease. All of these areas are already explained by the previous speaker, how it has been a large burden on the pediatric in the Bangladesh. So here I have summarized some of the priority area that are going to intervene in the Bangladesh. First of all, we are going to conduct the survey to understand the current situations and the burden of the pediatric NCD in the Bangladesh by focusing on the previous 4 diseases. And the second one, we are going to formulate the strategies and guidelines that are based on the finding of the survey or the assessment to integrate those into the existing ESP service package. And the third one is to develop the modeling, early identification, and the management of the pediatric NCD that is to increase the capacity of the service provider in terms of treatment to those pediatric NCD. And the fourth one would be to improve the data capture. So currently, right now, in Bangladesh, we have a very good health information system, that is the DHIS2. However, we have a very little information about the NCD situation in the country. UNICEF is going to provide the technical support in creating this data capture and integrating into the existing HMIS. And the fourth would be the community engagement for increasing the awareness, improve the behavior practices, and service utilization for pediatric NCD. And the last one would be by combining all those results, all those findings, all those interventions, we are going to provide the evidence-based policy advocacy on health systems. So these are our end result. So the project is aimed to be aimed for the next 4 years. That will be starting for 2022 to 2026. So from this project, we are expecting there will be a nationwide assessment survey, which will give us a glimpse of a current situation of the pediatric NCD in the country. That will lead to the formulation of the policy strategy for pediatric NCD. And in addition to this, the integration of the NCD-related indicator into the HMIS will allow the data visualization of NCD with real-time basis and enable the hospital managers, administration at the darker level to understand the burden of the pediatric NCD at a glance. And the third point will be by strengthening the supply chain management capacity at the national and the sub-national level for NCD. We are going to promote the drugs, commodities, and products. That does include a focusing tool for essential NCDs and drugs. And then lastly, we are going to have the up-to-date guidelines, SOP, training modules that are focusing on the pediatric care will be produced. So this is the last of my presentations. And if you have any questions, please raise your hands or put in the chat box. Thank you very much.
Thank you, Dr. Thancho. We will have a question-answer session for all the speakers later after the next presentation. Thank you again, Dr. Thancho. So now I would like to call the fourth speaker, Dr. Sheikh Daoud Adnan. He works in the hospital and clinics, DGHS, Mohakali, in transfusion medicine. He is a transfusion medicine specialist. He is also a joint secretary, AATM International, and secretary to AATM Bangladesh chapter.
Thank you for inviting me in first NCD conference. Distinguished guests and dear participants, welcome you all. Good afternoon and assalamu alaikum. I am Dr. Sheikh Daoud Adnan. I am working as a deputy director in DGHS, mainly works in the hospital and clinic section. And today I wish to talk about something about thalassemia, a health burden, a hidden health burden in Bangladesh, where we are standing and what is our future plan. You said that inherited hemoglobin disorders are emerging as a global public health concern, and it is estimated that 320,000 babies born each year with a clinically significant hemoglobin disorder. and nearly 80% of these births occurs in developing countries. If we make a most conservative estimate, we'll find that 5.2% of world population, nearly 360 million, carry a significant hemoglobin variant, and in excess of 100 million beta thalassemia carriers with a global frequency of 1.5%. We can say that 3 lakh to 5 lakh children born each year with the severe homozygous state of the hemoglobin variant diseases. It's the data from World Bank. By definition, thalassemia is an inherited hemoglobin disorder characterized by reduced rate of production of globin chain of hemoglobin. It is caused by a defect in the gene controlling the production of globin chain of hemoglobin. What is Bangladesh scenario? Bangladesh lies in world's thalassemia belt. It flows through, it has a definite geographical pattern. The information on different aspects of thalassemia like epidemiology, clinical course, mortality, complications, and treatment outcomes of thalassemia actually lacking in Bangladesh. The data are not available to us. But it is presumed from multiple studies that 3 to 4% of our Bangladesh population, 3% is beta thalassemia trait and hemoglobin E trait is 4%. If we calculate mathematically that roughly it is about 33 per 10,000 baby born in Bangladesh actually, would have a beta thalassemia or hemoglobin E beta thalassemia. And this is why the epidemiological data, there is lack of epidemiological data. That's why Bangladesh underestimates the future health burden resulting from thalassemia. And for effective addressing the control of this disease in Bangladesh requires considerable work, financial backing, and certainly political commitment. We have some political commitment in our Constitution, Article 15.1, where it is stated that the state will ensure basic healthcare services to all citizens of the country. We also have a national health policy which is adopted in 2011. It has 3 specific objectives: ensuring primary and emergency healthcare for all, enhancing equitable quality healthcare and accessibility, and third is promoting preventable healthcare services. We have operational plans in our 4th HPNSP, Health Population Nutrition Sector Plan. We have 3, we can say that our vision is universal health coverage with quality of life and reduce out-of-pocket expenditure. And our mission is to improve and sustain healthcare for people. Now come to our straight cut to our point in thalassemia. If we get thalassemia, we have 2 arms. One is management arm and one is prevention arms. If we go to the management arms, what we need to cover all the people. So we have to raise the area of diagnosis. And in the treatment arm, we, side by side, collect all the data from the diagnosis, who are the cases of thalassemia or the carriers. We'll bring them to our treatment arm. And side by side, we will also start the prevention model. And in prevention model, our target is zero thalassemia. If we go back to our previous slide, where we said that we want to extend our diagnostic area where thalassemia is underestimated in our country due to lack of diagnosis. If we enhance this area, we'll start with the clinical suspicion, where the pallor or anemia or any splenomegaly cases should go some basic tests. And we introduce these basic facilities up to district level. These basic tests are CBC, peripheral blood film, capillary hemoglobin electrophoresis, and serum ferritin. And in case of thalassemia, there is also, thalassemia comes with a lot of complication, and there is a lot of investigation about the complications also. And this is our diagnostic arm, and if we go to treatment arm, the basic treatment arm is blood transfusion and iron chelation. These are extremely basic. If we go to further improved treatment, then pharmacological agents for induction of hemoglobin F, splenectomy, stem cell therapy, treatment of complication, and also psychological support. And now, if we come back to our prevention stem, thalassemia is a preventable disease. Maybe there is a controversy among you about how a genetic disease can be preventable, but there is a prevention strategy. It is by creating awareness, population screening, avoiding marriage between carriers, genetic counseling, and preventing birth of affected fetus by prenatal diagnosis. Again, if we come about the successful population screening, in prevention system, we find that population screening has, there you see 4 steps. Screening of high-risk family members. When we find a case of thalassemia, we will test all the family members for thalassemia, who are thalassemia carriers or not. Childbearing potential group screening. Premarital screening. It is highly practiced in Iran or Pakistan, in some countries. Screening of pregnant mothers at their first visit. And in another also prenatal diagnosis, we can start amniocentesis and chorionuclear sampling. You see, this is our basic plan. Up to prevention we have shown. And now, probably this is the last slide. What we have developed up to this time through 4th HPNSP. We have developed 8 thalassemia management center, mainly based on 8 divisional headquarters in medical college hospitals, in either blood bank or hematology department. We make free consumables for the patients, blood bags, electrophoresis, diagnostic tools, blood bags, and iron chelating agents, everything. For definite treatment stem cell therapy, there is 2 centers in DMCH and CMH, and through our OP, we are trying to develop 2 centers, one in BSMU and one is National Institute of Cancer Research Hospital. And we have also developed a DNA lab in DMCH, CMCH, and expanded in 8 divisional headquarters. So, thank you.
Thank you, Dr. Adnan. Now we will have a short question-answer session. First, I would like to give opportunity to the online participants. You can type your question, or you can also take the speaker and ask your question. Then we will go in the audience. Thank you. Please mention the speaker you want to ask the question. Thank you. I have 1 or 2 questions in the chat box for Dr. Bedoura. Dr. Bedoura, are you with us? The question is, we are passing 2 years from pandemic. Do you have any data of developing new onset diabetes among our children during this period, when most of the time they are online classes? And the next question was also to Dr. Bedoura. What are your recommendations for prevention, motivation, as well as implementation of strategies to minimize the alarming childhood obesity and subsequent development of type 2 diabetes mellitus? Dr. Bedoura.
Yeah, thank you very much. I think the previous session there was a sound problem. Actually, we couldn't hear anything. Anyways, this is very important question, I should say. Yes, interestingly, for the last 2 years, we know we were passing through a difficult time. That's the pandemic time, the COVID-19. And the situation was definitely very difficult for the children as well as their parents as well, because The children are not having their normal activities, no schooling, nothing. And of course, there is impact of this. And in our hospital, in my Gurdon hospital, if you look into the endocrine and diabetes patients, the most patients we got in the endocrine department was the highest was the obesity, other than other endocrine problems. And in our diabetic centers, that is a really good finding. Though we didn't have any publication till now, we are working on it. That we got the increased rate. As I have shown that we were having up to 2018 to 19 was the type 2 prevalence in our center was like 20% in the new patients. In last 2 years, we found 30 to 40% were type 2 diabetics who are presenting, newly diagnosed patients who are coming to our diabetic centers in Gurdon. So, and your second question, yeah, I think that's the main thing we are discussing in this session, that how to prevent the obesity, how to prevent the type 2 diabetes in children. So I think you have seen in my presentation that we should start from the preconception time, because we have seen that another modifiable factor is the mother is having GDM. So we should work on that, okay, the GDM effect, we know two things. One is the mother can become the diabetic after the pregnancy or delivery. And the second thing is the child may have develop the pre-diabetes or diabetes condition. My diabetic centers in Gurdon, I would say only 7.5 years old, which is really alarming, is having type 2 diabetes. You can see that if you look into the criteria, even American Diabetes Association or ISPAT criteria, that we should start screening from 10 years. But unfortunately, we are having like more than 50 patients who are below 10 years coming to our Gurdon center. So you can understand that how to prevent, if you ask me, the first thing is the total changing of the pattern, lifestyle pattern, total changing of the dietary pattern. We should also, we know in even Europe, in some countries, they are having like, they are imposing tax, or like they are like making the soft drinks and other fast food a little higher price. In some centers, they are doing like that too, because we know it is very cheap and easily available. And in our setup, in our schooling, the children are having this cheap type of, the snacks. They're not having any fruit type of any snacks whole time. They're not having the physical activity which should they have in their early years. So you see, this is very important. If you don't change the lifestyle of your child or for yourself, you cannot change this trend which we're having in Bangladesh, the dual burden of obesity and underweight as well.
Thank you, Appa. The next question is for Dr. Brian. The question is, how will you plan to bring back patients of diabetes to the clinic or hospital for regular follow-up?
Thank you, Honorable Chair, Co-Chair, and learned speakers. It was a very fascinating session, and particularly it is so delighting to hear that Unicef has changed its direction from infection, not only changing, but adding its interest on top of, into an NCD on top of infectious disease. And this is really, really an important message for us who have been working in NCD in adults for a long time, because NCD children have a very different modality and pathogenesis, and their treatment and other mechanism for preventions are totally different than the adults. So my question is particularly to Tancho. So I am delighted to hear that you are going to conduct a plan for several research in Bangladesh. So it is, I don't know exactly how you are trying to organize that, but you probably will be coordinating with the NCD control program, and of course other institutions, organizations who have a huge knowledge, cumulative knowledge on NCD for the country itself. So I think this may be a coordinated effort for UNICEF, and it will be a great opportunity for us who are working in NCD adults to work with UNICEF in child NCD. Thank you so much.
Thank you for your great comments. Anybody else?
Assalamu alaikum. Good evening, everyone. I'm Dr. Sabiha Sultana. My question is to Dr. Thancha. that he already mentioned for UNICEF that NCD of pediatrics. So I have been already taken under WHO 2020, that was a adult NCD, that is a modified guideline. Still we are taking this updated guideline also and working under public health sector. I am also working IMU and migration, that there is also NCD, lots of people, and we a corner, we are doing this. But actually this is not a question. I would like to clarify myself too. Is there any pediatric NCD guideline developed yet or not?
Thank you very much. I would say that we do not have any actually national guideline on the part of the pediatric NCD yet in Bangladesh, and there has not been any guideline that has been set up for the international tool. You see, there are many issues about the pediatric NCD. There has been much of the hypothetical issues that whether the non-communicable disease started from the childhood or not. As because the atherosclerosis process is started from the very beginning of within the 10 years duration of time, it takes a huge number of time of years to pass to develop the NCD. This is a hypothetical issue. But there is no high quality evidence to say that how many years it's actually taken for the developing the NCD as a part of the atherosclerosis. This is one. Another thing is that there has not been high quality of the evidences on the part of the control of the risk factor issue like that what we are usually saying. These are detrimental. Can they start from the beginning and say whether the NCD can be stopped or not? Although there has been much of the, I would say that social issue of the improvement in the part of the Japan and others where the school health has been designed for the prevention of the NCD. But we need to have developed our own evidences in our country perspective to show the world that it actually works in our country perspective. The ethnicity-based diagnosis is very crucial, and so also for the age-based diagnosis, according to me. But this is a new issue. I will be very delighted if UNICEF came forward and we can generate few of the evidences so that at the later hour we can develop a guideline. Guideline should be evidence-based rather than just an empirical one, according to me. Thank you very much.
Thank you, sir. Now we have got Dr. Brian. Dr. Brian, there was a question to you. The question was, can you listen? Can you hear me?
Yes.
Okay, thank you. The question was, it was regarding patient scopomen, lack of health insurance coverage, lack of awareness are the main constraints of doing sophisticated investigation and prescribing originating molecules here.
Okay, I saw that. I was just about to type that. I think, firstly then, regarding INM prescribing versus originators, it comes back to what sort of regulations there are in the country and what sort of programs there are to encourage competition. The reason I say that, as I started typing away, work we did in the Netherlands a short while ago shows that we could get generic simvastatin. So Europe has good quality generics. We could get generic simvastatin and generic omeprazole for just 2% of the originator price. So that tells me, and we've got other low-cost generics as well in the UK and Sweden, etc. That shows me that we can get good quality, low-cost, multiple-source medicines with the right systems in place. There's no reason why we couldn't do that in Bangladesh. We have seen quite high use of, as I said in my presentation, of biosimilar long-acting insulin analogues. So that gives me some hope for the future. Lack of health systems coverage. I mean, this comes back into issues about how we utilize our resources, because if we fund, if you like, the complications of diabetes or heart disease in terms of treating patients with micro and macrovascular complications, then it's much better to put that money into prevention and make sure that these patients, including children, are well treated for their diabetes, heart disease, etc. So maybe we should look at cost effectiveness of that type of intervention versus waiting later on and the patients get complicated. And so that's just a question of reallocating resources. So I was very interested to see what UNICEF was saying on that. And lastly, what we have in some countries is that in terms of prescribing, then in Lithuania and I think in UAE, in countries like that, there's compulsory INM prescribing. and we have high voluntary INM prescribing in the UK. So maybe we can do things like that in Bangladesh as well. And I was interested to hear the comments about the improvements in collection of electronic data in health systems management situations. So maybe again we can look at that and say we should have issues then around prescribing of multiple source molecules versus originators, and particularly if some of the originators are without multiple sources, then like some of the GDP4 and some of those, the glinides and the glitazones and things like that. So maybe we should look and say, okay, in these patients, we want to include prevention, we want to include early use of drugs such as metformin, and then just monitor adherence to these medicines and the guidelines. And that negates the need then to move on to expensive medicines and helps the healthcare system as a whole. So, I mean, those were answers to the questions.
If no, we will go to our next part. Now I will call today's session's chief guest, Dr. A.E. Mohammad Mohiuddin Usmani. He is the Additional Secretary, Ministry of Women and Children Affairs, and also he was the former Division Chief, Planning Commission, Ministry of Planning.
Assalamu alaikum and good afternoon. I'd like to give thanks to the organizer for organizing first National NCD Conference of 2022. It looks that this is the first conference on NCD in this year, as now just January have started. NCD is one of the most important and most difficult area which we are dealing with. More than 70% of the death comes through NCD. So it is really a devastating area where we give less priority. We give more priority to other areas. And during this time, we identified that the many people are working in the NCD, especially in Bangladesh, and most of those are working especially in the clinical side. That means curative, though it is not curative, actually controlling the non-communicable disease. But in this session, and I think in the previous session, we do identify that NCDs are not curable till now, but a very big area we have, that is prevention of the NCD. And through government mechanism, we are talking about that we work on prevention of the NCD, but practically we are encouraging to have the NCD by encouraging our pre-factors, that means which are causing the NCD in the people, especially in the children, in the adolescent, in adults. That means our lifestyle and other area where we are not working appropriately. It is mostly because of our commercial thinking from different parts. Why NCD is very important? This is in today's first speaker, international speaker, Mr. Brian Godman. He do some pilot study on the NCD in Bangladesh, factors why more NCD, that means shortage of the trained manpower, cost with high co-payment, that is one, and the problem with the follow-up. So I actually had all this session papers, and one of the delighting paper is from Ms. Bedora Jabin about pediatric NCD, which is really very important. And now as I am working in the maternal and children area, that is Ministry of Mother and Women Affairs, Women and Children Affairs, so I do find out that really children need much more attention and much more attention than current situation if we would like to do something for our future. And one of those area is in the NCD also. To prevent it and to reduce our burden, we have to do it. And most important area in my front, our line director of NCD control of the DGHS is sitting. So I I'm very much appreciating him when he become the line director, because we have lot of gaps in identifying the risk factor of NCD and how to manage the NCDs. And I think by this time he spent a amount of time to identify our NCD activities of the government through fourth sector program. And also I request them to find out how to prevent, not to treat. Treatment should come for the clinicians, and treatment should come next. First of all, prevention, then identification, then diagnosis, and then treatment. And all of these need to have a good database. Right now, actually, I am writing one thing because I worked in the Planning Commission for at least 35 ministry, and at that time I identify so many success related to ICT in Bangladesh, that is through our Ministry of ICT, National Identification Data, that means NID number, then VAT, then government payment mechanism, mobile banking, many areas. We are so smartly competing with our other countries in the world. So in this data sector of Bangladesh health system, we also would like to have that type of example to set for the government. Actually, I worked for a long time in the Ministry of Health and Ministry of Planning for this area, and as a clinician, I do appreciate this type of conference, and I do eagerly waiting to have a good outcome from this conference. So I like to give thanks to all of you. Thank you very much. Assalamu alaikum.
The audience online and the people present here, I would like to thank you all, and also the organizer, and also the rapporteur, Dr. Rajak, and others helping in this organization. So I will request our to end the session. Today the chair is Professor Dr. Mohammad Sanwar Hossain, former chairman of Bangladesh Atomic Energy.
Good evening and assalamu alaikum to everybody. It's indeed a great pleasure for me to be here. First of all, I would like to convey my thanks and gratitude to the organizer, as this is the first time and this is the first conference of NCD in Bangladesh, and really I do appreciate it is organized by NCD of the ministry, Bangladesh Non-Communicable Disease Forum, and Non-Communicable Disease Research, Clinical Research Platform, and the Reporters Unity Platform, and many other stakeholders, both in government and private levels. And really, the team has worked hard, particularly the brilliant academician, Professor Dr. Obed Amin, and Dr. Shamim, and Dr. Alia Nahid, and his as their whole team. I do appreciate, and really with the highest gratitude, I would like to acknowledge them for their wholehearted effort to make this program is a success. And dear dignitaries and the learned audience, you know, these NCDs really is a very urgent and complicated issue in the field of health challenges, and it is globally very important, although we are struggling a lot with unprecedented COVID-19 pandemic throughout the globes. But we should not forget to combat the NCD scenario for the globes. And the scenario is almost same in our country. As I know from many of the speakers has correctly pointed out the necessity to address this issue. And this is the proper time to handle and to combat this situation. Otherwise, as you know, the incidence of the death through these NCDs almost more than 68% globally among the total death. So it is very crucial to decide to have some strategic plan and I do appreciate the Health Ministry of Bangladesh. They have already formulated a strategy that is multi-sectoral plan with the help of WHO. And this plan has probably from 2018 to 2025, and it has been categorized into two parts, in operational stage 1 and operational stage 2. I think if we follow this plan, and as you know, this Bangladesh government has improved in many aspects, including these health sectors, and we really very much thankful to the Ministry of Health for their proper and effective initiatives since after the power of this present government. And as you know, the current life expectancy of the peoples in our country population is 78.8 years, which was previously only 65.5 in 2000. So it is a symbol of improvement of the health system in our country. So many speakers today. We have our chief guest, Dr. Muhyiddin Usmani. He is the additional secretary and working in planning commission. He is actually my bestmate, and our reporter and the moderator from Unicef, and my fellow colleagues. Our four speakers, they are really learned speakers, has deliberately presented their papers. Jabin has pointed out, including the importance of the addressing this pediatric group, because many of the pediatric NCDs still is not properly being addressed, like rheumatic heart disease, the congenital hypothyroidism, thalassemia, and asthmatic disease, and all those diseases are very crucial, and that must be addressed properly in time. And one thing maybe I would like to add to include in this aspect, may I request and may I draw the kind attention of Dr. Jabin to include the neonatal hypothyroidism. And here is our honorable VCs here. So we have already a project in neonatal screening of hypothyroidism in neonates, because we can identify the neonates within the early days, so that any decision can be made for early diagnosis and treatment. So throughout the many NCDs cases, this case may be included. And Dr. Jabin has correctly pointed out many of the aspects of the issue, particularly the obesities and diabetes, and how to manage, how to early diagnosis, and the importance of the treatment, and including the awareness and our efforts to involve the multiple stakeholders. This is not only the works of the government, but we'll have to follow the global and international strategy. Like, we'll have to include many of the societies, many of the religious bodies and association and others. So collectively, we'll have to we'll have to try to combat this situation. As we are successfully managing the communicable disease in the country, we think that we do hope that similar way we can collectively try to combat these NCDs, and definitely with the collective effort we can manage in future. It can be an example for Bangladesh, the first time we can manage these NCDs through the multi-sectoral strategic plan. And I would like to thank the other speakers, particularly Dr. Daoud. He has correctly pointed out the importance of the thalassemia patients. And he has also pointed out the early detection devices like early diagnosis, screening, and maybe premarital screening, and also during pregnancy anomaly scan like placental analysis, villus sampling, and DNA analysis also. including the stem cell therapy. So many of the aspects he has already discussed about this issue. I think with these many aspects, this scientific presentation was really interesting. I would like to convey my thanks from our whole team to the speakers and to all the learned audience for your kind attention and for your kind interaction. I think if we follow the proper strategic plan and the formulated multi-sectoral plan to combat these NCDs in our country, we will be successful to manage in the similar way as we have already managed the communicable diseases in our country. With these few words, I would like to convey my thanks, wholehearted thanks and gratitude to the organizer again, once again, for their wholehearted effort to organize this as a grand conference on the NCDs. This is the first time. Really, it's a great achievement for our country to organize this type of conference in this year 2022. So with these few words, I'd like to thanks everybody for your patience sharing and patience and attention. Thank you all. Thank you very much for the organizer. Thank you. Assalamu alaikum.